sarro, el esmalte y los próximos 3 años de vida. Miren cómo raspa. Está cavando en busca de petróleo. Esa encía está sangrando.
Imagine you have the most unbearable toothache. You're walking down the street when you happen to come across a man who pulls teeth for a small fee. He convinces you and you agree to let him pull your tooth with a pair of pliers. What you don't realize is that this decision could cost you your life. Today we'll examine exactly what happens in the body when a tooth extraction is performed under non-clinical conditions, as shown in the video, and why tetanus is the most serious and silent risk in this scenario. Hi, we're the Team 11. I'm Sofia.
I'm Maisa.
I'm Angelica.
And I am Padme.
And this is The Hidden Price of a Smile. Now, let's provide some context. It turns out that in India, more than 60% of the population suffers from dental problems, but less than 4.5% visit the dentist, and only 47% of treatments are performed by licensed professionals. This happens for two main reasons. First, because there is no real public coverage for dental care. And second, because there is a cultural perception that oral diseases are not serious, which reduces the demand for formal care. It is in this gap that so-called quacks operate, unlicensed practitioners who treat lower-income populations, performing extractions using pliers and screwdrivers without any sterilization protocols. Now, the video highlights 4 major risk factors that need to be analyzed in this scenario. First, the instrument is rusty. The rough surface of the rusted metal creates microscopic cracks that trap spores from the soil. Rust itself isn't the problem, but rusty objects are often found in the same places where soil bacteria thrive. Furthermore, there is a complete lack of sterilization. Clostridium tetani spores are extraordinarily resistant to heat and most antiseptics. They can survive for years in soil, ash, and on tool surfaces. Similarly, since the instruments are not sterile, there is an even greater risk of transmitting disease from one person to another. Another downside is that the procedure was performed in a public space. The outdoor environment guarantees contact with soil particles contaminated by spores. And finally, there is no aseptic technique regarding oral tissues. The oral cavity creates an ideal anaerobic environment for spore germination. Extractions create open wounds that later become entry points for bacteria.
The causal agent. Given all of the above conditions, the primary pathogen here is Clostridium tetani, the bacterium responsible for tetanus. However, it's not the only one present. The oral cavity also exposes the patient to a polymicrobial infection involving bacteria such as Streptococcus mutans, Streptococcus mitis, Streptococcus salivarius, all alpha hemolytic bacteria belonging to the viridans group of Streptococcus, and others such as Neisseria flavescens, Fusobacterium nuclearum, Prevotella intermedia, Treponema denticola, and Staphylococcus epidermidis, as transient microbiota as well as Haemophilus parainfluenzae, among many others, but we have decided to focus on this anaerobic root-shaped gram-positive terminal spore-forming bacterium known as Clostridium tetani. But what is the clinical significance of this bacterium? Well, Clostridium tetani produces two toxins. The first is called tetanus plasmid, which is the second most lethal substance known after botulinum toxin. It travels from the wound to the central nervous system via retrograde axonal transport, where it blocks to the release of GABA and glycine, the inhibitory neurotransmitters. Without this inhibition, muscle excitation runs unchecked. At the molecular level, tetanus plasmid is a zinc-dependent metalloprotease that cleaves synaptic vesicular proteins, physically preventing the release of inhibitory neurotransmitters. There is also tetanolysin, a molysin that damages the tissues and optimizes anaerobic conditions for bacterial multiplication. The disease. Well, once the bacteria have entered the wound, the average incubation period is about 8 days. However, the closer the injury is to the central nervous system, the shorter the incubation period and the more severe the symptoms. In this specific case, the nearest nerves are the mandibular and maxillary nerves. Since food extraction occurs in the cephalic region extremely close to the brain, tetanus can develop more rapidly and with greater severity, often as cephalic tetanus before progressing to the generalized form. During the prodromal phase, the first 24 to 84 hours, the patient experiences general malaise, restlessness, jaw stiffness, and hypersensitivity in the wound area. These symptoms are so non-specific that they are often not recognized as tetanus at this stage.
Thing and symptoms. The first symptom in the 78% of the cases is trismus. Patients describe feeling as a throw, their jaw is locked, or that they can't chew. Ironically, it's usually a dentist who the patient visits first. As the disease progresses, other symptoms appear such as a progressive inability to open the mouth, difficult swallowing as if something were blocking the throat, stiffness and the pain in the neck or and back, painful muscle contraction triggered by noise, light or touch, fever and profuse sweating. They are two distinct diagnostic signs of the disease. Rhesus sardonic, which is a spasm of the facial muscle that produces a fixed smile, which raises eyebrows, and the opidonos, which is a generally arching of the body due to the simulation contraction of extension the muscle. At this point, the spatula test is performed, which involves touching the oropharynx with a spatula. The normal reflex is to try expel it, but in the patient with tetanus, a reflex spasm occurs and they immediately bite the spatula involuntarily. Progression of the disease. The progression of generalized tetanus follows the next stage. The day 1 to 3, trismus, sardonic smile, and the neck stiffness. The days 3 and 7, rigidity spreads to the trunk, abdomen, and the extremities, severe dysphagia, and opisthotonos. The days 7 and 14, generalized paroxysmal spasms, labile hypertension, tachycardia, and hyperhidrosis. Weeks 2 to 4, critical stage, severe dysautonomia with sympathetic hyperactivity. The most critical complications include the respiratory fault due to the laryngeal spasms, aspiration pneumonia, rhabdomyosis, which is a breakdown of damaged muscle tissue, releasing toxic substance such as myoglobin into the blood to cause acute kidney failure, arrhythmias, and several organ damage, bones fractures to the violent spasms, and a cardiac arrest to dysautonomia. Generalized tetanus results death in approximately 1 to 10 cases.
But I'm sure you're now asking yourself, how can we diagnose it? The diagnosis of tetanus is primarily clinical, but is supplemented by anaerobic wound culture, positive in only 30% of cases, PCR for the TXT gene, ELISA for anti-tetanus toxoid, IgG antibodies. And once diagnosed, how can we treat it? Treatment follows a hierarchy based on severity. Human tetanus immunoglobulin can be administered to neutralize free circulating toxin, but it has no effect on toxin that is already bound to the nerves. Antibiotics such as metronidazole, which is used against anaerobic bacteria, are also administered. This drug is preferred over penicillin because penicillin can inhibit GABA receptors by sharing a mechanism with the toxin itself. Benzodiazepines are prescribed to control spasms. 4-magnesium sulfate is also used for dysautonomia. In cases that do not respond to the above, neuromuscular blockers are administered with mechanical ventilation. To this day, innovative approaches are being pursued to treat this infection. The use of botulinum toxin has been explored as a paradoxical antidote for localized forms of spasms, acting in opposition to tetanospasmin at the neuromuscular junctions. As for after effects, complete recovery is possible, but survivors of severe tetanus face long-term consequences. In a study of 50 survivors, 19 experienced subsequent psychological effects. All showed some degree of tracheal stenosis and hypoxic brain damage due to apnea during the spasms, which may be irreversible. In short, after going through all of this and surviving tetanus, some might think they have at least developed immunity, but the unfortunate reality is that they haven't. The infection does not confer immunity because the amount of toxin needed to cause the disease is very small. It's not enough for the immune system to generate lasting protective antibodies. Therefore, every patient who survives must complete the tetanus toxoid vaccination scheme. A tooth extraction in the street using a rusty, unsterilized instrument can trigger one of the most devastating neurological diseases known to medicine. Tetanus is preventable with a vaccine, so please get vaccinated. And the next time you have a toothache and see an open-air dental clinic, please think twice.